So in this session we'll deal with the pleura. So pleura is a serous membrane. The pleural cavity is a serous sac into which the lungs grow and reduces it into a potential space, and dividing the pleura into two layers. There will be a visceral layer or the visceral pleura or the pulmonary pleura which lines the lung, and there will be a parietal pleura which lines the parietes of the thoracic wall. You can see here the growing lung bud growing into the pleural sac. So reducing the pleural sac into a potential space, making the pleura into two membranes, that is the visceral pleura lining the lung and the parietal pleura lining the thoracic wall, separated by endothoracic fascia. You can see here, if you observe, so this is the visceral pleura which lines the lung, whereas if you see the parietal pleura, it has been divided into four. Namely, you can observe this is the cervical pleura, this is the cervical pleura in the neck. So you can see this is the costal pleura which lines the sternum, ribs, intercostal spaces and sides of the vertebra. And here you can see the diaphragmatic pleura which lines the thoracic surface of the diaphragm. And here you can see the mediastinal pleura which lines the mediastinum. So parietal pleura is having four parts: the mediastinal pleura facing the mediastinum, the cervical pleura facing the neck, the costal pleura lining the back of the sternum, the ribs, intercostal spaces and sides of the vertebrae and the intercostal muscles. And here you can see the diaphragmatic pleura lining the thoracic surface of the diaphragm. Now if you observe the cervical pleura continues on the medial side with the mediastinal pleura, and beyond the inner border of the first rib it continues with the costal pleura. The cervical pleura is covered superiorly by the suprapleural membrane or Simpson's fascia. Suprapleural membrane or Simpson's fascia, which is a musculofacial partition. So any structure related to the cervical pleura is outside the suprapleural membrane. The suprapleural membrane is mainly made up of scalenus minimus muscle and endothoracic fascia. So on the lateral aspect it is attached to the inner border of the first rib. Above it is attached to the transverse process of the C7 vertebrae, and medially it continues with the pretracheal fascia. So it protects the apex of the lung and the cervical pleura from the neck root structures. So then you can see the costal pleura. The costal pleura continues behind the sternum with the mediastinal pleura along the costo-mediastinal reflection, and also behind it covers the sides of the vertebra and continues with the mediastinal pleura along the costo-vertebral line of reflection. So here on the inferior lateral aspect, the costal pleura becomes the diaphragmatic pleura along the costo-diaphragmatic line of reflection. Let us see these lines of reflections. So if you observe the costo-mediastinal reflection, on the right side and left side, it starts from the sternoclavicular joint, it extends downwards and medially to the sternal angle. Then also it continues vertically downwards up to the level of fourth costal cartilage. So costo-mediastinal reflection is common up to fourth costal cartilage on both sides. But if you go beyond the fourth costal cartilage, on the right side, it goes vertically downwards up to the xiphisternal joint, then it deviates laterally along the seventh costal cartilage, okay, and continues with the costodiaphragmatic line of reflection. Whereas here on the left side, due to presence of heart, the costo-mediastinal reflection slightly deviates away from the midline and descends in relation to the lateral aspect of the sternum. It reaches the sixth costal cartilage. So from there it goes laterally and continues with the costo-mediastinal reflection, same as on the right side. So this is the costo-mediastinal reflection. Difference is present on right side and left side below the level of fourth costal cartilage. So you can see here same thing again, the costo-mediastinal reflection. So here you can see the costo-diaphragmatic reflection. Here you can see the costo-diaphragmatic reflection. So here you can see the costo-mediastinal reflection. So this is on the right side and this is on the left side. So it is common on right and left side up to the level of fourth costal cartilage. After that, it is slightly different on the right side and left side. So you can see the costo-diaphragmatic reflection. So you can observe here. So after the xiphisternal joint, so you have to mark 3 points. So in the mid clavicular line, at the 8th rib, in the mid axillary line, the 10th rib, and 2.5 centimeters lateral to the T12 spine. Okay, so these 3 points will mark the costodiaphragmatic reflection. So from xiphisternal joint. This is on the right side. On the left side, this first point differs. So this first point stands at the sixth costosternal joint. Sixth costosternal joint. And remaining points are same. This is the costodiaphragmatic reflection. You can observe here between the lower border of the lung and the lower end of the pleura, there is a large gap forming the costodiaphragmatic recess. Okay, or phrenico-costal sinus. So now you can see the costovertebral reflection. So it is the reflection along the line joining a point 2.5 centimeters lateral to the 7th cervical spine and a point 2.5 centimeters lateral to the 12th thoracic spine. So it is along this line where the costal pleura becomes the mediastinal pleura posteriorly on the side of the vertebrae. So now you can see the relations of the mediastinal pleura above the lung root. So if you see, this is the right lung. So there is superior vena cava and right brachiocephalic vein. You can see the right common carotid. This is the right brachiocephalic trunk, the right phrenic nerve, and the right vagus nerve. You can see the trachea and esophagus. And on the left side, you can observe the left common carotid artery, left subclavian artery, the left vagus and the left phrenic nerve, left brachiocephalic vein, and left superior intercostal vein. You can see the left recurrent laryngeal nerve, the esophagus, and the thoracic duct. So these are the relations above the lung root. You can also see the arch of azagus vein here. Here you can see the left superior intercostal vein. You can see the inferior cervical cardiac branch of the vagus, and you can see the superior cervical cardiac branch of the left sympathetic chain. You can see the arch of aorta. So these are the relations above the lung root. And if you come at the level of the lung root, you can observe here. So this is the lung root where important vasculature and bronchus are present, which are entering and leaving the lung. The most important thing at the lung root is the structures arranged at the lung root. So this is the lung root. So this is the below the lung root, it forms a pulmonary ligament. This is at the level of lung root. So if you observe the structures within the lung root, on the right side and left side, from before backwards it is same. If you observe from before backwards, it is the superior or the upper pulmonary vein, the pulmonary artery, and the bronchus. So this is from anterior to posterior or from before backwards. But if you see from above downwards, it is different on right side and left side. On right side, from above downwards, it is the epiarterial bronchus, the pulmonary artery, and the hypoarterial bronchus, and the lower pulmonary vein. Whereas on the left side, it is the pulmonary artery, the principal bronchus, and the inferior pulmonary vein. So it differs from above downwards on right and left side. Whereas from anterior to posterior or from before backwards, it is same. That is the from anterior to posteriorly, it is superior or upper pulmonary vein, pulmonary artery, and the bronchus with the bronchial vessels. So the relationships of the mediastinal pleura below the lung root. So you can see here, this is the pulmonary ligament which extends from the side of the esophagus to the corresponding lung. So anteriorly you can see between the pericardium and the mediastinal pleura there is phrenic nerve. You can also see here behind the esophagus there is mesoesophagus where the mediastinal pleura of both sides are coming close. So when the esophagus crosses the descending thoracic aorta. So now if you see the pleural recesses, you can observe here the costodiaphragmatic recess opposite 8 to 10th ribs, a semilunar recess between the lower end of the lung and the lower end of the pleural reflection where the costal pleura becomes the diaphragmatic pleura. So this is the semilunar recess, costodiaphragmatic recess, otherwise called as the phrenico-costal sinus. And here you can see the costomediastinal recess where the costal pleura becomes the mediastinal pleura behind the sternum. Two recesses are there. Out of that, most important is the costodiaphragmatic recess because this is the most dependent part. So where there will be accumulation of fluid. If there is accumulation of fluid within the pleural cavity, this is the first place to where the fluid gets collected. It is semilunar in shape. As I have shown earlier, you can see here the costodiaphragmatic recess is widest in the mid axillary line. It is approximately around 5 centimeters. The lower end of the lung is above 5 centimeters, the lower end of the pleura. You can see here the accumulation of fluid within the pleural cavity is called pleural effusion. You can see the collection of fluid in the costodiaphragmatic recess. So thoracocentesis is the pleural aspiration, essential in the assessment of pleural effusion and also in order to treat the pleural effusion. So first we do a chest radiograph which will confirm the location and extent of the effusion, and the clinical examination will identify the best position for aspiration. The best position is the posterior mid-scapular line, which is the commonest site. The skin of the desired intercostal space is cleaned and anesthetized. The aspiration needle is inserted at the inferior margin of the space because the main intercostal vessels run in the superior region of the space. After appropriate local anesthesia, the needle is carefully advanced in a perpendicular direction through the facial and muscular layers of the thoracic wall until it passes through the parietal pleura and enters the pleural cavity. So more complex or small effusion should be aspirated under ultrasound guidance. You can see here, this is the thoracocentesis, pleural space filled with the excess fluid. You can see the fluid being collected into the bag. It is done in sitting position. So needle thoracocentesis. So needle thoracocentesis is performed when a life-threatening tension pneumothorax is suspected. A needle is inserted in the second intercostal space in the mid-clavicular line on the affected side. A sudden escape of air is heard when the needle enters the parietal pleura. A thoracostomy followed by chest drain incision must subsequently be performed within the revised triangle of safety after this procedure. You can see here, this is the triangle of safety: anterior fold, posterior fold, and the nipple or fifth intercostal space. This determines the triangle of safety. So this is the triangle of safety. So here you can see the pneumothorax. So where the air is entering into the pleural cavity. So this is like open pneumothorax, like air entry and exit is both are present. So not much of life threatening. But if you go to this condition, specific tension pneumothorax, when there is valvular, that is only unidirectional entry of air into the pleural cavity, but there is no exit of air, then there is increasing pressure within the pleural cavity and there is collapse of the lung. You can see there is collapse of the lung. So there will be pleuritic chest pain, shortness of breath, cough and fever, tachycardia, tachypnea, hypoxia, hypoxemia, hypotension, and tracheal deviation. So this is a life-threatening condition. So immediately there should be needle decompression in the second intercostal space, the mid-clavicular line, followed by insertion of the chest tube. You can see here the needle decompression being done into the pleural cavity. So chest drain insertion. The site for thoracostomy and chest drain insertion is usually the fourth or fifth intercostal space between the mid-anterior axillary lines. Revised triangle of safety. So between the mid and anterior axillary lines, revised triangle of safety. So the thoracostomy is performed via 2 cm horizontal skin incision followed by blunt dissection, often using a clamp, through the subcutaneous tissue to the superior border of the inferior rib of the space, then through the intercostal muscles. Then the parietal pleura is penetrated with the tip of a clamp and a gloved finger inserted in the pleural cavity to release pleural adhesions. This is called pleural sweep. The chest drain tube is then inserted in the pleural cavity and attached to an underwater sealed container placed below the level of the lungs. The fluid level should rise and fall in the tube with ventilation. You can see here, this is how a chest tube is inserted. Thank you.